Picture two men. The first is at a lively dinner party on a Saturday night. We'll call him Mark. He's a professional, good job, nice apartment. He's laughing, pouring another generous glass of wine for his friend. Later in the evening, someone might discreetly pass around a little something extra to keep the energy up. For Mark and his friends, this is just part of the texture of a successful life, a way to unwind, to celebrate, to connect. It's a choice. Now, picture the second man. We'll call him David. It's a Tuesday afternoon. He's in a small flat, sitting on the sofa. The TV is on, but he's not really watching. He opens a can of cheap, strong lager. For him, this isn't a celebration. It's medication. It's a way to silence the constant grinding stress of unpaid bills and an uncertain future. It's a routine born not of choice, but of a lack of them. Here is the paradox that lies at the heart of our society. If you look at the data, Mark, the man at the party, is statistically more likely to drink to excess and use illegal drugs than David. But if you ask which one of them is more likely to die from it, the answer, by a staggering margin, is David. This isn't an anomaly, it's a pattern. It's a phenomenon so consistent it has a name, the harm paradox. And it forces us to ask a deeply uncomfortable question. If addiction doesn't start with the poor, why does it so often end with them? The answer reveals a truth that's less about personal failings and more about the invisible architecture of the world we've built. That opening story about Mark and David, it really brings home a deeply uncomfortable truth, doesn't it?
It really does. It gets right to the heart of the issue.
It highlights that there's something far more complex at play than just individual choices when it comes to substance use and its devastating consequences. Today, we are taking a deep dive into what we're calling the harm paradox, this idea that addiction doesn't start with the poor, but it disproportionately ends with them.
Mm-hmm.
We're going to try and pull back the curtain on this invisible architecture that shapes health outcomes, particularly around substance use disorders. We'll explore the underlying social, economic, and systemic factors that don't just influence health, but often, it seems, predeterminate.
Right. They set the stage in a way.
Exactly. And to truly understand this, we need to shift our gaze, I think, from the individual to the environment itself to what experts call the social determinants of health. Can you help us unpack what that term truly means and, why it's so fundamental to this paradox?
Absolutely. It's compelling how the narrative around addiction has historically fixated on individual responsibility or, a perceived moral failing.
Yeah, that's the easy story, I guess.
It is. But as we unpack this, you'll discover that the evidence points to something much broader and, frankly, far more systemic. It's about the fundamental conditions in our society that create vastly different pathways for people. These aren't just minor influences, they are foundational elements. They dictate a wide range of health, functioning, and quality of life outcomes and risks, including, very much so, a person's vulnerability to substance use disorders. This is precisely what we refer to as the social determinants of health, or SDOH. It's about the structural factors that either support health or, actively undermine it, often before an individual ever makes a conscious choice.
That's a crucial shift in perspective, moving beyond individual actions to the very environments people inhabit. It's the context, not just the person.
Exactly. The context is key.
So if we're talking about this invisible architecture, what are the key blueprints? What are the core domains that actually make up the SDOH?
Right. So there are 5 key domains that are widely recognized, for instance, by the U.S. Department of Health and Human Services. They really constitute SDOH. First, we have economic stability. And this isn't just about how much money someone has right now. It's about consistent, reliable access to income, steady employment, and just overall financial security.
Oh, daily grind stuff?
Precisely. Think about the daily stress of unpaid bills, the constant worry about eviction, or simply having enough money for food. That's economic stability or instability at play. Second, there's education access and quality. This covers a lot, really. Everything from early childhood education and literacy rates, right up to access to higher education and job training.
Opportunities, basically.
Yeah. It's about whether someone has the opportunity to gain the knowledge and skills that open doors to healthier lives and more stable futures. Good education often correlates with better health literacy, healthier choices and greater economic opportunities down the line. Third, healthcare access and quality. This seems obvious, maybe, but it's about more than just having insurance.
Right. Just having a card doesn't mean you can actually get care.
Exactly.
Yeah.
It's about the availability of affordable, high-quality healthcare services, doctors, specialists, mental health support, preventive care, and critically, whether those services are culturally competent and, geographically accessible. If you live in a rural area with no clinics, or if you can't afford a copay, your access is fundamentally limited. Fourth is the neighborhood and built environment. This domain looks at the conditions of where people live, work, and play.
So the physical space.
Yes, and the social space too. Does a neighborhood have safe, affordable housing? Is there reliable public transportation? Is the air clean? Are there safe parks and green spaces? Or is it characterized by, dilapidated buildings, lack of public amenities, pervasive violence? These physical and social conditions profoundly shape daily life and well-being. And finally, fifth, social and community context. This is about the relationships and interactions within a community.
How people connect or don't.
Right. It includes social integration, the strength of support networks, and exposure to factors like discrimination, violence, or conversely, community cohesion. Do people feel safe and supported? Do they belong? Or are they isolated, facing systemic biases that erode their sense of worth and opportunity? And it's really important to remember, these 5 domains don't operate in silos. They are deeply interconnected.
They all feed into each other.
Exactly. They influence each other in complex ways throughout an individual's entire life course, creating these cumulative impacts. Think of it like a ripple effect across a lifetime, where one challenge can easily trigger others, making things progressively harder.
That paints a much fuller and frankly a more challenging picture, and it certainly connects right back to David's situation in the opening. His daily reality is dominated by what we described as that grinding stress from unpaid bills and an uncertain future. It's stark how economic instability could be such a huge driving force in substance use.
Precisely. Economic instability is a profound predictor of vulnerability to substance use disorders, and the mechanisms are, well, multifaceted. We see direct links between factors like employment and income and the risk of overdose death.
Really? There's data on that?
Oh, absolutely. For example, individuals who are unemployed or disabled face significantly higher odds of overdose death, sometimes more than double compared to those who are employed. Even certain occupations, often those with low wages, precarious employment, or high physical demands like service industry roles, construction, or installation and maintenance, carry a relatively higher risk of overdose death.
Wow.
So it's not just about earning an income, it's about the chronic, unrelenting stress generated by a lack of stable employment and housing. For someone like David, substance use isn't really a recreational choice, is it? It becomes a maladaptive coping mechanism, almost a form of self-medication to manage the relentless anxiety, despair, and depression that come with chronic financial precarity.
Trying to numb it out.
Basically. Imagine living in a constant state of fight or flight, never knowing if you can pay rent, if you lose your job, or if your utilities will be shut off. That pervasive, grinding stress can overwhelm a person's natural coping abilities, pushing them towards anything that offers temporary relief, even if it's harmful in the long run.
So it's not just about having a job, but the stability and type of work and how that feeds into daily stress levels.
That's a huge part of it.
What about something even more fundamental, like food? You mentioned basic needs. Could that possibly factor into addiction vulnerability?
Absolutely. It seems almost too basic, but consistent access to nutritious food plays a definite role. Evidence indicates that lower food security is significantly associated with higher odds of using illicit substances.
Like cannabis, stimulants, opioids?
Yes, exactly those. When you're food insecure, it's not just hunger, right? It's an added layer of daily stress, uncertainty, and physical discomfort. That just exacerbates existing vulnerabilities and makes turning to substances for escape or relief seem, well, more appealing, or maybe even necessary at times.
It's another source of that constant grinding pressure.
Precisely. And this illustrates how the architecture of disadvantage can be built across generations. It creates pathways for vulnerability long before an individual makes what might seem like a choice to use substances. The longitudinal impact here is profound. Parental education and income levels, for instance, can influence a child's risk of substance use initiation much later in life.
So stuff that happened when you were a kid affects your risk years later.
Definitely. Think about it. A child growing up in a household struggling financially might experience chronic stress themselves. They might witness their parents grappling with limited opportunities or have less access to enriching environments and healthy coping mechanisms, things like after-school programs, stable housing, supportive community networks. These early life conditions, often invisible to outsiders, can subtly but powerfully steer a child's trajectory. They build pathways for vulnerability.
Which really speaks to the importance of things like targeted anti-poverty programs and social safety nets, doesn't it? If they can disrupt those pathways early on.
That's a critical point. When implemented effectively, Programs that provide stable income, affordable housing, quality education, accessible healthcare, they directly disrupt these causal pathways you're talking about. By providing the stability and resources that can mitigate chronic stress and improve overall well-being, such initiatives don't just alleviate immediate hardship. They can actually prevent the initiation and reduce the severity of substance use from the outset.
Like a buffer.
Exactly. They effectively provide a safety net that catches individuals before they fall into patterns of harmful coping. They address the root cause, not just the symptom.
That's a powerful point.
Yeah.
The intergenerational impact and how these foundational programs can disrupt the cycle. And speaking of long-term impacts and foundational vulnerabilities, we absolutely need to talk about the profound weight of trauma. It seems like trauma, especially early life experiences, is just a critical factor in vulnerability to substance use disorders.
It truly is. Trauma is broadly defined as an event or a series of events or circumstances that an individual experiences as physically or emotionally harmful or threatening. And critically, it has lasting adverse effects on their well-being across mental, physical, social, emotional, or spiritual dimensions. What's crucial to understand is that trauma isn't just a single isolated incident. It can be a chronic pattern, and it can be experienced individually by families, entire groups, or even whole communities. It's a pervasive shadow that can influence lives for decades.
So it's not just about, say, one dramatic event, but potentially ongoing exposure to adverse conditions that can shape a person's entire life trajectory.
Exactly. That's a key part of it. This is particularly evident when we look at adverse childhood experiences, or ACEs.
ACEs, right. I've heard that term.
Yes. These are potentially traumatic events occurring in childhood, from birth to 17 years old. They encompass things like experiencing violence, abuse, or neglect, but also aspects of a child's environment that undermine their sense of safety and stability. This includes things like parental separation, mental illness within the household, or parental substance use.
Things that make a kid's world feel unsafe.
Precisely. And the link between ACEs and later substance use disorder is, frankly, alarmingly strong. For instance, experiencing 4 or more ACEs can increase the odds of injecting drug use in adulthood by approximately 7 times.
7 times? That's huge.
It is. And specific ACEs, such as parental substance misuse and family homelessness, are known to significantly increase the risk of later SUD.
That's a staggering statistic, 7 times. It really forces us to question that common perception of addiction as solely a series of bad personal choices. It sounds like vulnerability is woven into a person's life almost before they even have a conscious memory.
The profound insight here is that these aren't just isolated events or past wounds. They are literally shaping the very foundation of an individual's developing brain and their capacity for resilience.
So it affects brain development.
Yes, which raises that important question about the longitudinal impact of these systemic socioeconomic inequalities and cumulative stress. Prolonged exposure to traumatic events, particularly in early childhood, can literally interrupt normal brain development. This isn't merely psychological, it has a neurobiological basis. The brain's architecture, especially areas responsible for executive function, emotional regulation, and stress response, can be profoundly altered.
How so? What does that look like?
Well, when the brain is developing under constant threat and stress, think chronic food insecurity, witnessing violence, experiencing neglect. It can lead to negative impacts on cognitive functioning. It can make it harder to learn, plan, and problem solve. It also often impairs emotional regulation, meaning individuals struggle to manage their feelings and impulses. They might react to stress with intense emotional outbursts or withdrawal rather than, thoughtful processing.
Less ability to cope.
Exactly. And it significantly diminishes psychological resilience, the ability to bounce back from adversity. This helps explain how vulnerability to SUD can become deeply ingrained, almost wired into an individual's biology. They may turn to substances not out of a desire for pleasure, but out of a deep-seated, biologically driven need to quiet an overactive stress response system or to numb overwhelming emotions.
It really shifts the conversation from what's wrong with you to what happened to you.
Precisely. And perhaps more importantly, how can we repair the systemic damage that allowed this to happen in the first place?
So trauma isn't just a personal wound. It's often a societal one that literally reshapes the individual. It's truly a social justice issue, isn't it?
Absolutely. Minority and under-resourced communities disproportionately experience trauma. This is often due to systemic issues like racism, genderism, homophobia, transphobia, poverty, sexism, and ableism. These systemic traumas can have severe, long-lasting, and crucially intergenerational impacts. When entire communities are subjected to collective complex trauma, it perpetuates vulnerability across generations.
Can you give an example of how that community-level trauma might manifest? What does that look like on the ground?
Sure. Think about growing up in a community where every public park is run down, where there's visible drug use on the streets, where the local schools are underfunded, and where neighbors are too stressed or disconnected to form strong support systems. That creates an environment of constant low-grade stress and perceived threat. Historically, practices like redlining, which deliberately divested from certain neighborhoods for decades, created cycles of poverty, limited economic opportunities, and eroded social cohesion for generations. That's a profound form of community-level trauma baked into the system.
The history shapes the present reality.
Exactly. The very architecture of the neighborhood, the damaged social networks, the limited economic and educational opportunities they can reflect and perpetuate that trauma. It makes it incredibly difficult for individuals to find safe havens, build resilience, or access healthy alternatives to coping with pervasive stress. It's a literal feedback loop where external stressors manifest as internal vulnerabilities, making people far more susceptible to turning to substances as a coping mechanism.
And this leads us directly, it seems, to the role of systemic racism and the criminal legal system in perpetuating trauma and increasing vulnerability to addiction. It's like a constant re-traumatization machine for some communities, isn't it?
Indeed. The over-criminalization of drug use and the disparate policing of Black, Indigenous, and people of color, BIPOC communities are well documented. And this persists even though data consistently shows Black and white individuals have comparable rates of illegal drug use.
So same behavior, different consequences.
A starkly different set of consequences often. It's a clear contrast in how different groups are treated by the criminal legal system for the same behaviors.
It's truly a double standard. What are some of the most striking examples of these racial disparities within the criminal justice system?
Well, Black and Hispanic individuals are disproportionately represented in jails and prisons for drug offenses. We see this clearly in arrest rates, sentencing, and incarceration durations. But it doesn't stop there. The criminal legal system often mandates inappropriate treatment that doesn't align with evidence-based practices.
Like forcing treatment that doesn't work?
Or worse, limiting access to essential medications for opioid use disorder, like methadone or buprenorphine, while people are incarcerated. In some cases, these vital, life-saving medications are outright refused. This not only undermines effective treatment and recovery, but also pushes individuals back into the cycle of substance use upon release, often with even fewer resources and options than before. It sets them up to fail.
And I imagine the consequences of these convictions extend far beyond prison walls, creating that ripple effect you mentioned, making it nearly impossible to rebuild a stable life.
You're absolutely right. We call these collateral harms, and they are extensive, pervasive. Nonviolent drug convictions lead to a cascade of exclusions from fundamental societal anchors. Employment, safe and affordable housing, access to loans, professional licensure, even civic participation like voting in some states.
So many doors just slam shut.
Imagine finally being released from incarceration, eager to turn your life around, only to find that every door you try to open, for a job application, an apartment lease, a student loan to retrain, is slammed shut because of a decades-old drug conviction. This creates a cycle of marginalization and poverty that actively traps individuals, making stable recovery an incredibly difficult, almost Sisyphean task. It's like having an invisible barrier preventing you from re-entering society fully.
That sounds like it actively works against recovery, not for it. What about families, especially those with children? I've heard the Child Protective Services system can also be a source of trauma in these situations.
This raises a profoundly important and often heartbreaking question about systemic bias in Child Protective Services, or CPS. Parental substance use is unfortunately a frequent cause for CPS referrals. That's a reality. However, despite similar rates of illegal drug use between Black and white parents, Black families are significantly more likely to be drug tested, reported to CPS, and critically, have their children removed from their homes for longer periods with less likelihood of reunification.
Wow, so the bias follows them there too.
It does. This demonstrates how systemic biases within health and legal systems can actively re-traumatize and destabilize families, creating a new generation of trauma and perpetuating the very cycle of vulnerability we're discussing. It's a tragic feedback loop.
And then there's this phenomenon that some refer to as white exceptionalism that seems to have shifted the public narrative around addiction in the U.S. more recently. Can you explain that and how it's influenced our understanding and response?
It's a compelling observation about how societal perceptions can be shaped by demographics, by race. Historically in the U.S., drug policies and public perception often associated drug use, particularly things like crack cocaine back in the 80s and 90s, with blackness. This association was then used to justify highly punitive measures, mandatory minimums, harsh sentencing, a massive expansion of the prison industrial complex under the banner of the war on drugs. The narrative was largely one of criminality and moral failure.
Lock them up.
Pretty much. However, a significant shift occurred in the public discourse when the face of addiction began to look visibly more white, particularly with the opioid crisis gaining prominence in suburban and rural areas. Suddenly, addiction was reframed. It became a medical condition deserving compassion, understanding, and effective treatment rather than vilification and incarceration.
A public health crisis, not a crime wave.
Exactly. This white exceptionalism highlights how systemic biases can dictate not just individual outcomes, but also the very policies, funding priorities, and public empathy directed toward a health crisis. It underscores how much the invisible architecture is shaped by underlying racial dynamics. It creates vastly different societal responses to similar problems based on who is perceived to be affected. It's a stark illustration of how race can fundamentally alter public and policy responses to what is, at its core, a public health challenge for everyone.
It's clear that understanding these deep-seated root causes, the SDOH, the trauma, the systemic racism, is vital. But it also helps us understand why accessing care, getting actual help, is so incredibly difficult for many marginalized individuals. There are just so many roadblocks.
Indeed. For people experiencing homelessness and problematic drug use, the barriers to accessing traditional health and social care are profound, and they often compound each other. One major pervasive issue is the institutionalized stigma and dehumanization they frequently face.
The judgment.
Yes. Individuals consistently report humiliating experiences and discriminatory treatment from staff in essential services, hospitals, social services, even addiction treatment centers sometimes. This understandably leads to a high level of mistrust and ultimately disengagement from care. Why would you go back if you feel judged or mistreated?
Can you give us some concrete, maybe vivid examples of what that feels like for someone? What does that discriminatory treatment actually look like on the ground?
Participants in various studies have recounted truly distressing incidents that illustrate this dehumanization vividly. For instance, some describe nurses or doctors treating them differently, their tone shifting, their eyes hardening the moment they see methadone or substance use disorder flagged on their medical records.
The label changes everything.
It changes the entire dynamic of care, from one of potentially compassion to one of suspicion or judgment. Others have recounted experiences of being subjected to degrading strip searches upon entering a detox unit, or by police on the street. This led to intense anxiety and a profound sense of powerlessness, feeling like their body and dignity were constantly under invasive scrutiny.
That's horrifying.
Imagine trying to seek help for a deeply personal struggle, only to be met with procedures that re-traumatize you and strip you of your dignity. It creates a powerful, almost insurmountable deterrent to seeking future care. It cultivates a deep-seated mistrust in the very systems designed to help.
It's hard to imagine prioritizing anything over getting help when you're in crisis. But I guess when you're literally fighting to survive day to day, healthcare takes a backseat.
Absolutely. For people experiencing homelessness, immediate survival needs like securing food and shelter often take existential precedence over consistent engagement with healthcare. If you don't know where your next meal is coming from, or where you'll sleep safely tonight, attending a scheduled appointment, adhering to a medication regimen, or following a long-term treatment plan becomes an impossible luxury. These immediate pressing needs consume all mental and physical bandwidth, pushing any other concern, no matter how critical, to the margins.
And what about the places provided as emergency accommodation, like hotels or hostels, especially during the pandemic? They were supposed to help, right? But sometimes it sounds like they end up making things worse.
That's a crucial point about the unintended and often devastating consequences of well-intentioned initiatives that lack adequate planning, resources, or frankly, a trauma-informed perspective. While programs like Everyone in the UK provided emergency housing during the pandemic, which was necessary, many participants reported being re-traumatized by what they described as toxic environments in these temporary accommodations.
Toxic.
They spoke of the prevalence and accessibility of illicit street Valium, often described as being bought like sweeties, directly within these temporary shelters. This made it incredibly difficult to avoid drug use, especially for those trying to achieve sobriety. Imagine trying to get clean in a place where drugs are easier to get than support. Living conditions were often inadequate. No hot meals, lack of facilities like kitchens or washing machines leading to poor nutrition and hygiene. And most tragically, participants spoke of regularly witnessing death in these settings. One individual explicitly mentioned 8 people have died just in that B&B alone. 3 of my neighbors, your man across, by taking his dodgy street Valium. That affects me.
Oh my.
And then I lost my pal and all. Died with street Valium. These environments, meant as shelters, inadvertently became sites of continued trauma, exacerbated drug use, and profound grief, creating an impossible cycle to break for those already vulnerable.
That's truly horrifying. It's the opposite of a healing environment. And what about when they do manage to get into treatment? Do they feel like they have any autonomy, any say in their own care decisions?
Sadly, often not. Participants frequently express significant frustration with feeling excluded from decision-making, particularly concerning crucial aspects of their care, like methadone prescriptions. They reported feeling not listened to, being denied access to detox or rehabilitation programs they desperately wanted, and struggling to access vital counseling for things like bereavement, a huge issue given the constant loss they witness, as we just heard. This profound lack of autonomy reinforces the sense of powerlessness that many already experience in their lives. It further erodes trust in the very systems meant to help them. It really underscores the urgent need for service delivery models that are designed with these specific challenges in mind, prioritizing the individual's voice and agency.
Okay, so if these traditional approaches are so riddled with barriers, what's the path forward? You've mentioned integrated care as a potentially transformative approach. How does that work in practice, and what makes it different?
Right. Integrated behavioral health, or IBH, represents a fundamental shift in how we conceive of and deliver healthcare. It's really about recognizing that physical health and behavioral health are inextricably interdependent. They're not separate entities operating in isolation.
Mind-and-body connection, basically.
Yeah, exactly. The goal is to seamlessly integrate these services into both primary care settings, where people often first access healthcare, and into specialty behavioral health settings. The aim is ambitious, but crucial, to improve the quality of care, enhance the patient experience by making it more holistic and accessible, and importantly, to do so in a cost-effective manner. This is what people often call the triple aim in healthcare. It moves away from that fragmented care where a patient might see a doctor for a physical ailment and then be sent to a completely separate facility for mental health or addiction issues, often with zero communication between the two providers.
That sounds like a dream for many people navigating the system, moving beyond that fragmented care. What are the core components that actually make IBH effective, especially when serving vulnerable populations like David, facing all those SDOH barriers?
Well, to truly implement effective IBH, particularly for low-income populations facing multiple SDOH barriers, several core components are absolutely critical. They have to be pursued rigorously. First, team-based care is essential. This means moving beyond a single provider model to multidisciplinary teams. Think doctors, nurses, therapists, social workers, case managers, both physical and behavioral health professionals working collaboratively, ideally under one roof or through very close, seamless coordination. And it's crucial to invest in appropriately trained staff. This means not relying on low-cost but under-trained clinicians, as that can actually undermine effective care and perpetuate the very barriers we're trying to dismantle. These teams need to communicate constantly, sharing insights and developing unified care plans.
Everyone on the same page.
Exactly. Second, we need universal screening. Just like taking vital signs, blood pressure, temperature, regularly screening all patients for behavioral health issues in primary care settings, and conversely, screening for physical health issues in behavioral health settings should become routine. This vital signs approach removes the burden from patients to spontaneously disclose their struggles, which we know is often difficult due to stigma. It significantly reduces the risk of missed or unaddressed needs. Imagine being screened for depression or anxiety as routinely as your blood pressure is checked. It normalizes the conversation and identifies issues much earlier.
Makes it less scary to bring up.
Precisely. Third is the unwavering commitment to evidence-based practice. This means consistently using proven interventions and adhering to best practice guidelines for both physical and behavioral health conditions. It ensures better outcomes and cost-effective care. This isn't about guesswork. It's about utilizing therapies and medications demonstrated by research to be effective for specific conditions and tailoring them to individual needs. Fourth, and perhaps most crucially for individuals who have experienced marginalization and trauma, is person-centered planning and shared decision-making. This is a profound shift.
Doing with, not to.
Exactly. From providers doing things to people to doing things with them. It means engaging patients actively in defining their own needs, setting their own goals, and choosing their preferred treatments. Given the historical stigma and disempowerment many have faced, truly listening to and incorporating the patient's voice is vital for ensuring active and ongoing participation. It rebuilds trust and fosters a sense of agency that is often severely eroded by their life circumstances. For example, offering choices in therapy modalities or involving them in setting realistic, achievable recovery milestones makes a huge difference. Fifth, data sharing and population health management are key for effective and efficient care at a system level. This involves real-time clinical data sharing among all providers in the healthcare network: hospitals, emergency rooms, specialty clinics, primary care. This improves care quality by providing a complete picture of a patient's health history, helps avoid errors and redundancies, and crucially, allows for the identification of high-need patient subgroups for targeted proactive interventions. For instance, identifying patients with co-occurring chronic physical and behavioral health conditions who would benefit most from intensive integrated support.
Using data to actually improve care.
Yes. And finally, we need progress monitoring and quality improvement. This means continuously assessing both intermediary outcomes, like patient engagement, which can be measured by tools like the patient activation measure, gauging a patient's knowledge, skills, and confidence for managing their own health and ultimate health outcomes alongside cost measures. It's a continuous feedback loop that allows organizations to learn, adapt, and refine their services, ensuring they are truly effective and consistently improving. This comprehensive approach, tailored to the complex needs of low-income populations facing multiple SDOH barriers, represents a significant best practice in overcoming historical challenges in access and engagement. It's foundational to healing the harm paradox.
It's clear that integrated care is a major step forward, addressing that fragmentation head-on. But layered on top of that, or perhaps underneath it, given everything we've discussed about trauma, is the profound need for trauma-informed care, TIA. How deep does this approach go in healing and effective treatment?
Trauma-informed care, or TIA, is more than just a set of practices. It's a fundamental philosophical shift in how an organization operates. It's a strengths-based approach designed to create safer environments for both clients and staff. It's about explicitly recognizing the widespread presence of trauma symptoms and acknowledging the profound role trauma has played in people's lives. The goal is to promote safety, empowerment, and healing. It's not just an add-on service. It involves intentionally incorporating these principles into an organization's entire structure, service delivery, and culture. The primary aim is to avoid re-traumatization and actively foster healing.
So it's about making absolutely sure that the very process of getting help doesn't inadvertently cause more harm. That seems incredibly vital for someone who has already experienced so much trauma and mistrust.
Exactly. It means designing every single aspect of care to be therapeutic, not re-traumatizing. This could involve, for instance, avoiding the use of physical restraints unless absolutely necessary and as a last resort, or being highly sensitive about invasive procedures that could be triggering for someone with a history of physical or sexual abuse. It's about creating an environment where individuals feel physically and emotionally safe enough to begin healing, rather than being constantly reminded of past harms to the very systems meant to help them. This is particularly crucial for low-income populations who have often experienced multiple cumulative traumas throughout their lives.
How does an organization actually go about implementing this comprehensively? It sounds like a massive undertaking requiring a complete cultural shift, not just a new program.
It absolutely requires a multi-domain approach and a deep commitment from the top leadership down. It's not something you can just check off a list. First, in training and workforce development, all staff, clinical and non-clinical, must receive comprehensive training. This means everyone: organizational leadership, administrative personnel, reception staff, security guards. Everyone needs to understand the prevalence and impact of trauma. This training isn't just about recognizing trauma in patients. It also includes understanding secondary traumatic stress and burnout in staff themselves. And critically, it must address diversity, equity, and inclusion, DEI principles.
Why DEI specifically?
Because the goal is to foster a profound sense of belonging for BIPOC and LGBTQI+ communities, actively countering the othering and discrimination that so often accompanies marginalization and trauma. This helps to dismantle the institutionalized stigma we discussed earlier, making care feel genuinely welcoming and safe for everyone. Second, the physical environment where services are offered must foster both physical and psychological safety. This goes beyond just being clean and well lit. It involves thoughtful design, considering noise levels, privacy, comfortable seating, even the type of artwork on the walls. Crucially, input from individuals with lived experience should be sought to identify strengths and areas for improvement, ensuring the space itself feels safe, calming, and conducive to healing, rather than cold, clinical, or institutional.
Getting input from the people who use the services.
Absolutely essential. This leads to the third, profoundly important domain, engagement and involvement. There must be meaningful representation and active involvement of individuals with lived experience, those who have personally experienced trauma and substance use, in the design, delivery, and ongoing evaluation of services. This ranges along a continuum from simple outreach and consultation to full partnership, emphasizing shared decision-making at every level. Promoting robust peer support programs is also vital here. Peers, individuals who have walked a similar path, can offer understanding, empathy, and practical guidance in a way that professionals sometimes cannot. They foster a sense of hope and solidarity.
That shared experience is powerful.
Incredibly so. Finally, in screening, assessment, and treatment, TIA introduces critical distinctions. It differentiates between universal, brief trauma screening, a quick, routine way to identify if trauma has occurred, and in-depth trauma assessment, which is conducted by a trained clinician for a holistic and nuanced understanding of an individual's trauma history and its impact. The treatment services themselves must be trauma-specific, culturally appropriate, evidence-based, and accessible, rigorously adhering to TIA principles. Examples of effective evidence-based trauma treatments include cognitive processing therapy, CPT, eye movement desensitization and reprocessing, EMDR, and seeking safety, which integrates treatment for both trauma and substance use. This comprehensive implementation is crucial for rebuilding trust, fostering empowerment, and tailoring services to the unique, complex needs of low-income populations facing deep SDOH barriers. It's key to effectively addressing the challenges we've outlined.
This sounds like a fundamental redesign of how healthcare, especially behavioral healthcare, is delivered. Moving from reactive and sometimes harmful to truly proactive, preventative, and compassionate. To make these integrated and trauma-informed approaches a widespread reality, though, we need to talk about the big systemic solutions. Policy and funding. How do we shift that invisible architecture of support to truly make this happen on a national scale?
This raises a really important and often tricky question about how we finance such transformative care models. Developing a sustainable financing approach for successful integrated behavioral health is often a significant challenge for providers, mainly because traditional funding streams are geared towards siloed, separate care.
The money follows the old model.
Exactly. So it requires a careful examination of patient insurance coverage and identifying ideal partners. For instance, when a significant portion of the patient population has Medicaid, partnering with federally qualified health centers, or FQHCs, can provide a more sustainable revenue base. FQHCs are community-based health providers that receive federal funding and have comprehensive funding structures specifically designed for Medicaid and uninsured clients. This makes them ideal partners for integrated care models in underserved communities.
So it's about finding diverse funding streams, not just relying on one source to ensure long-term stability for these more holistic models.
Precisely. Organizations really should proactively pursue multiple funding sources. That includes public insurance programs like Medicaid, commercial insurance, client self-pay where feasible, state and federal grants, and even private philanthropy. What's also quite compelling here is the potential flexibility of managed care organizations, or MCOs. These are essentially the health plans that manage care for their members. While they often operate on traditional fee-for-service models, the critical point is their ability to negotiate their own fees and rules directly with providers.
They have some wiggle room.
They do. They're not rigidly bound to conventional payment structures. They can innovate if they choose to. For instance, an MCO could create a bundled payment for a whole episode of integrated care services, or offer specific incentives for providers who demonstrate improved patient outcomes through IBH. This flexibility makes them powerful potential partners in supporting these transformative models, moving beyond the fragmented, siloed care that often fails those most in need and leading to a more seamless, effective experience for patients.
What about the perceived cost of all this? Is integrating these services immediately cheaper? Because, policymakers often look for those quick returns on investment.
That's a crucial point for policymakers, and the immediate cost effectiveness is, complex. Integrating primary care into behavioral health settings might not immediately result in cost savings. In fact, short-term costs might even rise as previously unidentified physical and mental health needs are discovered and finally addressed.
Finding more problems initially.
Right, which is actually a good thing for the patient's health long-term. However, if we connect this to the bigger picture and look at the long-term impact, Integrating behavioral health services into primary care settings does yield significant long-term healthcare cost savings for common conditions like depression and anxiety. This suggests a strategic approach might be needed, prioritizing integration efforts where they are likely to yield the greatest financial benefit and overall public health impact. It's an investment that pays off over time by improving overall health and reducing the need for more expensive, crisis-driven interventions later on.
So it's an investment that pays dividends down the road, especially in certain contexts. And beyond funding, what fundamental policy shifts are needed, particularly regarding the criminal legal system and racial justice, to truly support this new architecture of care?
This is where advocating for deep systemic change becomes paramount. It's about truly dismantling that invisible architecture that perpetuates harm and inequality. We absolutely need to shift the national response to personal substance use from primarily a criminal issue to fundamentally a health issue.
Health, not crime.
Exactly. This means eliminating criminal and onerous civil penalties for personal drug and drug paraphernalia possession. It might even mean considering the expungement of past records to remove those devastating collateral consequences we discussed earlier, allowing people a real chance to rebuild. What's particularly striking here, and worth repeating, is that even though Black and white individuals have comparable rates of illegal drug use, Black and Hispanic individuals are disproportionately over-policed and incarcerated for these offenses. So, a key policy priority must be eliminating this over-policing of BIPOC individuals and actively addressing racial disparities in civil enforcement. The criminal legal system, quite simply, should not interfere with or influence the assessment, diagnosis, or treatment decisions for substance use disorder.
Treatment decisions belong in healthcare, not courtrooms.
Absolutely. Treatment decisions must be made by clinicians in partnership with patients, not by courts or correctional facilities.
It sounds like taking the crime out of addiction is a core tenet for racial justice in this space. Are there real-world examples of this working? Has anywhere actually done this?
Portugal offers a compelling and very well-studied example. Back in 2001, they decriminalized the possession of all drugs for personal use. Critically, this wasn't done in isolation. It was implemented as part of broader public health and social reforms that significantly ramped up investment in treatment and harm reduction services.
So decriminalization plus investment in health.
Yes, the combination is key. The result was not a surge in drug use, as many feared. Instead, they saw improved health outcomes, including reduced rates of HIV infection and overdose deaths and decreased drug-related crime, all without legalizing drug access or supply.
That's powerful evidence.
It demonstrates powerfully that a public health approach, rather than a punitive one, can be highly effective and much more humane. Ultimately, we need robust, sustained investments for evidence-based prevention, early intervention, harm reduction, and treatment services, with a specific emphasis on youth and racially and ethnically minoritized people who have been historically underserved and overpenalized. This includes expanding access to life-saving medications like buprenorphine and methadone and naloxone for overdose reversal across all healthcare settings, emergency departments, hospitals, primary care clinics. These are not just treatment options. They are vital tools for saving lives and fostering recovery right now.
This all brings us back, in a way, to one of the most foundational social determinants of health we discussed: housing. It seems like stable housing isn't just a social service, it's actually a critical health intervention that can truly disrupt these cycles of addiction and harm.
You're absolutely right. What's particularly striking here is the two-way street between housing stability and substance misuse. Instability dramatically increases the risk of misuse. I mean, if you don't have a safe place to sleep, where are you possibly going to focus on recovery?
Makes sense.
Conversely, substance misuse can significantly impact housing stability, creating this vicious cycle that's incredibly hard to break. Stable housing, therefore, acts as a profound protective factor. It offers a fundamental foundation upon which individuals can begin to build recovery and address other pressing health needs. Without a stable home, consistent engagement with any form of care, medical, mental health, addiction treatment is incredibly challenging, if not impossible.
So how do we actually put this into practice? Is there a model that prioritizes getting people housed right away without demanding sobriety first? Because that seems like a major barrier in traditional approaches.
Yes. This is where the Housing First model, or HFM, comes in. It's an evidence-based approach that prioritizes providing immediate housing to individuals experiencing homelessness without preconditions like sobriety or mandatory participation in treatment. This stands in stark contrast to traditional models that often require individuals to demonstrate readiness for treatment, achieve sobriety, or adhere to strict rules before they can even access stable housing. Housing First operates on the principle that housing is a basic human right and a fundamental prerequisite for successful recovery and reintegration into society. Get people housed, then offer support.
And does it actually work? It sounds almost too straightforward, maybe even counterintuitive to some for such a complex problem.
The evidence is incredibly compelling and really debunks many conventional assumptions about needing to earn housing. Housing First models have been rigorously studied and shown to effectively decrease homelessness, improve housing stability, increase utilization of behavioral health services, and significantly reduce substance misuse.
Wow, so it hits multiple targets at once.
Exactly. It demonstrates its efficacy in simultaneously addressing multiple social determinants of health, breaking that self-perpetuating cycle of homelessness and addiction. It's a powerful testament to how a single, fundamental intervention, a safe, stable home, can create a cascade of positive effects across various aspects of an individual's life and health, including their ability to engage with and benefit from treatment when they are ready. When people feel safe and secure, they are much more able to address underlying issues.
That's truly impactful. Are there government initiatives or programs already in place that support this kind of integrated housing and health approach across the U.S.? Is this happening anywhere systematically?
Yes. Thankfully, there are several, and collaboration between agencies is growing, which is encouraging. Federal grant programs like SAMH's Treatment for Individuals Experiencing Homelessness, (ADH), and Grants for the Benefit of Homeless Individuals, GBHI, are specifically designed to expand access to behavioral health treatment, recovery support, and, crucially, housing services for this vulnerable population. More broadly, the U.S. Interagency Council on Homelessness launched the All Inside Initiative back in 2023. This is a significant effort. It brings together 19 federal agencies, including SAMHS, HUD, Housing and Urban Development, and others to navigate funding complexities and address major systemic barriers for homeless populations. That includes healthcare access, substance misuse prevention, and housing solutions. It's about bringing the full force of federal resources to bear on these interconnected challenges in a coordinated way.
And what about public housing itself? Does that play a role, perhaps, as a direct source of stable homes for people?
Absolutely. HUD's Office for Public and Indian Housing, or PIH, plays a critical role here. It oversees local public housing authorities that provide rental housing and related services for low-income families, older adults, people with disabilities, and American Indian Alaska Native families, all populations that are unfortunately at increased risk for substance misuse due to various SDOH factors. Their housing choice vouchers, which many people know as Section 8, are particularly impactful. They serve over 3.5 million households across the country. These vouchers provide rental assistance, significantly reducing the financial burden of housing. And research shows they have been effective in reducing homelessness and associated substance use problems. They provide that critical, stable home base that allows people to focus on other things.
So it's clear that housing is a central, perhaps the central piece of this puzzle, serving as that protective factor. What opportunities are there for collaboration between organizations focused on substance misuse prevention and those in the housing sector? How do we connect these efforts better on the ground?
There's immense and often untapped potential for collaboration and synergy between these critical sectors. It's truly exciting to think about the possibilities. Prevention organizations can actively integrate substance misuse prevention efforts into HUD's continuum of care. COCSI programs, for example.
What are COCSIs?
COCSIs are local planning bodies that bring together diverse community partners, homeless service providers, government agencies, nonprofits, faith-based groups, to coordinate housing and services for people experiencing homelessness in a specific geographic area. Prevention organizations can become active COCSI members themselves. They can provide vital opioid education, distribute naloxone in public housing settings or shelters, directly reaching high-risk populations in the places they live and frequent. Furthermore, they can partner specifically with Housing First model programs to offer supportive services after housing admission. This means prevention education, naloxone distribution, and connecting residents to treatment and recovery support can happen once individuals are safely housed and their most immediate survival needs are met. This makes them far more receptive to engagement.
Meeting people where they are.
Exactly. Meeting people where they are, literally and figuratively. Ultimately, advocating for broader policies that support both primary prevention efforts and universal housing access in communities is a powerful way to make systemic change. It's about building a comprehensive safety net that addresses the roots of the harm paradox, not just reacting to its consequences.
This whole deep dive has truly changed how I think about addiction. It's just so much more than an individual failing. It's this deeply complex challenge shaped by profound systemic forces and, frankly, glaring inequalities. The story of Mark and David at the beginning really grounds it all, doesn't it?
It does.
Mark, with all his privilege, is statistically more likely to use, but David, despite potentially lower use, is far, far more likely to die. It's just stark.
It's compelling how the data itself forces us to move beyond those simplistic notions of choice and willpower. Addressing the harm paradox requires us to grapple with the intricate connections between socioeconomic factors, the deep and pervasive impact of trauma from individual ACEs to chronic community-level stressors, and the severe systemic barriers to accessing effective, compassionate care. It highlights, really, that the outcomes are often predetermined, or at least heavily weighted, by the invisible architecture of disadvantage that surrounds people.
So what does this all mean for how we move forward, for changing David's reality and the reality of so many others like him?
Well, it means true. Lasting progress won't come from a punitive mindset that blames the individual. That approach has clearly failed. Instead, it demands a fundamental shift towards comprehensive, integrated, trauma-informed, and socially conscious approaches. We must prioritize stability, dignity, and healing for all individuals. We have to recognize that by intentionally repairing the invisible architecture of disadvantage, through robust social safety nets, equitable policy, decriminalization, and truly compassionate care systems, we can genuinely disrupt the cycle of harm. We can build a more equitable path to recovery, making a healthier future not just an aspiration, but a reality for everyone.